Hi, good morning, everyone. Welcome to the latest session in our webinar series from the University of Minnesota with M Simulation. My name is Lou Clark, and I'm the Executive Director of M Simulation, and I'm here as your host of the webinar to introduce this series and briefly introduce the session. I'll be asking you a few questions via poll in just a moment. And then I'm going to turn it over to really my outstanding colleagues, Dr. Mojca, our medical director, John Chaika, Eugene, Floersch, members of her team. And behind the scenes today, a thank you to Nick Newman, who is driving our slides in our Zoom. Next slide, please. So we have nothing to disclose. I think that's important to say, so putting that right out there. Next slide. Today, for your audience participation, please type your questions actually into the Q&A. We're going to try to leave some time for Q&A today. We think we can. And also know that the recording of this session will be posted on our M Simulation website early next week at the latest. And also, if you have missed and want to see previous sessions of this webinar series, we have Zooming with SPs already posted. We also have our session on interprofessional education that is now posted, so you can access those via the website. Next slide, please. So also always want to give thanks and acknowledge our entire M Simulation team. Every time I do this, I feel like it's super important to say that several of the people on this list are part-time employees. We include them. They are valuable members of our group, helping us to carry on our education in these online settings. So thank you to our entire team. Next slide, please. Also, it's important for us to acknowledge our leadership that has been supporting us through this time. We're now coming to the end of week 6 since we've entered this time of COVID-19 response. So thank you so much to the leaders at our institution and also our communication team that helps us get the word out to you about the information we're sharing. Next slide, please. So for those who haven't joined us before, this is our 3rd session today in a webinar series that we call Healthcare Simulation Online, COVID-19 Response in 2020 and Beyond. And I think the and beyond part is so important because while this time necessitates immediate, rapid transition to online settings for much of our education, we know we will get beyond it. So what we're trying to do this for you every other Friday, and the goal of our series is to present events or information that we have implemented and tested, including practical knowledge, skills, and training methods. Next slide, please. So today we have a session that's a little bit different than the ones we presented before. I'm very excited about it. What we're going to do today is share some incredibly innovative work the team has done to leverage simulation education resources and support our frontline clinicians who are providing this COVID-19 response with those simulation education resources. And those resources are first and foremost our incredible team of presenters, our staff and faculty, in addition to some of the equipment they'll be sharing. And it's interesting because they've used this equipment in ways in which it wasn't necessarily intended. So I think we're all going to learn a lot from this. So the objectives today are to describe the use of Glo Germ for experiments to study the COVID-19 spread, to identify uses of simulation to uptrain clinical staff, central and arterial line training, ICU skills, and we're going to learn something new about SimMan respiratory physiology as applicable to our ventilators during the COVID-19 pandemic. So this is what we're going to cover today. But before we do, we want to take a quick poll, and let's bring up our first poll question. It's really going to be about how are you leveraging your resources. So the first 2 questions are, and if you could please weigh in, we'd love to know. Are you leveraging simulation education resources to support frontline clinical care in your COVID-19 response? Yes or no? If you answered yes to the first question, what simulation education resources have you been using? Have you been using, working with your staff, mannequins, Glo Germ, task trainers, video and online platforms? And I believe we also have the opportunity for other. And if you do select other, we're going to ask you to please note that in the Q&A, because it won't tell us what the other is. So if you've done something super creative, we want to share it with everybody. So please put that in the Q&A. I see someone already put into the chat, donating supplies. Fantastic. So again, tell us what it was. Go ahead and take a couple more seconds to answer our poll questions, and then we'll share with the audience. All right, Nick, if this seems like a good response, let's share the results. Okay. All right, so number one, are you leveraging simulation education resources to support frontline clinical care in your COVID-19 response? I think this is really exciting. 75% of those who answered the poll said yes, they were. Fantastic. We have 25% that says no, not yet. We hope that you'll get some additional information to support you in doing this, whether you're already doing it or whether you want to do it, you haven't done it yet. That's why we're here. So the second question, if yes, what education resources have you been using? 45% of you say simulation education staff have been contributing to this. That's fantastic. 39% say mannequins. We've been able to continue using our mannequins. 16% say Glo Germ. 28% say task trainers. 52% say video or online platforms. And we know that's been a big push for all of us. And then we've got 37% that say other, which is excellent. I've seen some people answer, a lot of people answering donating supplies. Some people say they've written COVID scenarios, which is fantastic. And they also recommend checking out the Laerdal website. There's some free resources on there. And I'm looking more answers. Reassigned Sim Center director to draw blood work for our COVID study. What else? Lots of donations. Didactic training around donning and doffing. Donating PPE. So a lot of donations. Wonderful. So we thank you for those, the work you're doing and your contributions. And now I'm going to turn it over to Dr. Mojca Konia to get us started and tell us about the work we've been doing here in Minnesota.
Maybe before. Nick, if you can turn my video on, that would be great. And then maybe before we get into specific questions, I'd also like to know what the answers to the third question that we had will be from the larger group. And what we wanted to know, since we were working with our larger healthcare system here and have received quite a bit of support from them, did your institution support your efforts in your COVID-19 response? I will give a little bit of time because I think this is an important question to understand the environment we're living in. Certainly this situation with COVID-19 is a significant strain on every institution around the country. And we were just wondering to understand how your institution has been handling this. Nick, maybe whenever you feel the responses are in, we can look at the results. So we see, this is great to see that many institutions are very supportive of us, which is, I think, a very important piece of information for all of us. So this is great to see for me personally, that we're not sort of sidelined at this moment. So wonderful, wonderful slide to see. Lou, thank you for the introduction, and I'm very excited to share with you today some of the stuff we've done in our clinical environment. And basically what we've done is addressed COVID-19 in maybe three larger groups of themes. Some of the clinical questions were related to COVID-19 spread. How does it spread? And how could we best protect ourselves against it? The second larger theme that kind of surfaced was the need for uptraining of personnel. The hospital really came to us with the need to uptrain nurses towards ICU and nurse anesthetists towards full scope of their practice. And then the third larger group of themes that came up with was related to ventilatory support of patients. We've all sort of heard in the news that ventilators are in short supply. And so we have done the studies where we were looking at how we can repurpose certain pieces of equipment towards what we need right now. And then the hospital also reached out to us to study the environments within the hospital that they would have to repurpose from a non-intensive care unit environment into an intensive care unit environment. That piece is not necessarily very innovative, but I think the questions surrounding how do we go into the environment, do we expose our personnel and things like that were of interest to us. Next slide, please. So as far as the spread of COVID-19, the first project tried to investigate how small micron-sized particles travel within the different ventilatory circuits. We were looking at anesthesia machine circuits, intensive care unit ventilators, non-invasive positive pressure ventilators, and high-frequency oscillators. Those are all different kinds of ventilators used in intensive care units and in the anesthesia environment. And the question that we wanted answered was, when is it safe not to use full personal protective equipment? That becomes very important because pretty much all around the country, the PPE, as personal protective equipment is called, is in severe shortage. If I give you a sense, in our hospital, we have 2 days worth of gowns. That's the most recent information from today. So 2 days. We have 6 days worth of surgical masks. Those are regular masks. So these are some serious issues. And if we can understand that maybe in a certain setting, the use of all the equipment is not necessary, and we can save some of the equipment that was important to the clinical teams. So that was the first sort of group of projects. Next slide, please. And in order to study this, we had to figure out a way how to use, what to use first, and then how to use the fluorescent marker that would help us investigate if certain circuits with the ventilators are leaking or not. And for that, we attempted to use Glo Germ. And John is going to tell us a little bit just about the technical issues of figuring out how to aerosolize it, and then also some of the challenges that arose from the things that Glo Germ does to our equipment. So John, if you can share some of these experiences, they were certainly quite interesting.
Yeah, so Dr. Konia came to me with the task of being able to kind of visualize the aerosolization of patients via a mannequin, and then handed me a bottle of Glo Germ and said, see what you can do. So, you know, as sim specialists are, we like, yeah, let's do it. Let's find a way. So me and Eugene, not having an aerosolization equipment, kind of came up with stuff in our lab to aerosolize Glo Germ. So Glo Germ used primarily in teaching how to wash hands, aseptic techniques, that kind of stuff, and glows under UV light. Comes in 2 major forms, lotion and a powdered form. And then it does also come in a mist form, but we weren't able to get our hands on any of that in time. So not having this aerosolization equipment that MACM program would have. I just went back to my medical background and what we use in our sim lab and just used a basic nebulizer and some O2 tubing and some air to aerosolize like it should. What we did to start with was we used a half and half mixture of water and glycerin to aerosolize, which is the same as a smoke machine. We've used this in the past to create the airway fire effect in our mannequins. So I figured if we use that and try to introduce the Glo Germ to it, it should take. What we found is that the lotion is way too viscous and it wouldn't actually aerosolize. And when it did, it only kind of stuck around the initial nebulizer equipment. So then we moved and we mixed it in the powdered Glo Germ, and that actually worked fairly well. We were able to detect Glo Germ particles all across the inside of the airway, as well as into the circuits when not using the appropriate HEPA filters and such. This kind of allowed us to play around with which mannequins we wanted to use it in. As you see on the screen, we have a Laerdal airway head. And this is from an old study. We have a few of these airways left that we use for just airway training for the most part. What we did is we took that nebulizer and the T-piece and connected it at the lung level and did a flow of 6 liters per minute to aerosolize it all. And it was a constant stream, so it was coming out the mouth. You could see the smoke, and then you could also see flecks of the powdered Glo Germ kind of accumulate around the mouth. So that kind of achieved our mission success, that we can visualize it. We can make the mannequin kind of breathe. And then that's kind of where it led to these other projects where we added a high flow nasal cannula and BiPAP to the mix, and it showed actually a lot of aerosolization happening with those two specifically. And then with the anesthesia machine, we saw if you didn't use a HEPA filter, it would actually go up into the circuit and start to reach the anesthesia machine. Now, bringing it back to the mannequin level, we definitely wanted to use this mannequin torso as our base, because if you're not really familiar with the insides of the simulator, it can get very, very hard to clean with all those tight spaces and electronics. So I think it is safe to do so with a regular SimMan if you have the technical abilities to open them up and know how to close off the airway and all that. But I would say that, as you can see, it made it quite messy. So the best way for us to clean it up really was just, soap and water and then an alcohol solution. Took us a couple hours to get it all off, but it did eventually get all of it. We did eventually get all the stuff off the skin. So after that I've said that, I'm gonna push it back to Dr. Konia and she can kind of put it back together.
Great. And so the images below, as John already mentioned, are of a BiPAP machine, and there's little particles on the mask and also on the drape right around the head, which would mean that this would be spread into the air if anyone is present in the room, they would be exposed to the infection. And on the very right bottom, there's the high flow nasal cannula, which is quite high flows of oxygen through it to support the patient, but it causes a lot of spread of the microparticles, as you can see. And that equally would be a problem clinically. And for that reason, at present, these two techniques which could potentially breach patients from or prevent the patient from having to be intubated are not used because the risk of exposure of everybody around is too high. Next slide, please. The second project that investigated the spread of COVID-19 was a simple question: is there a way to protect healthcare providers from frank exposure? In the clinical relevance of a question like this is, number one, you'd protect your healthcare workers, which is clearly a very important piece, and the rate of infection for us is about 10%, which is pretty high. You could also potentially avoid some of the invasive treatments because, for example, the slide before where we were looking at how the Glo Germ was all over the patient's head, if you had a way to isolate that, you could potentially use those two modes of ventilatory support in a safe manner and avoid having to intubate the patient. And the third thing is certain procedures have basically stalled clinically. And if you had a way to isolate the frank exposure, you could probably proceed with some of the procedures that we're not doing at all currently in clinical environment. Those would be like bronchoscopy, for example. Next slide. And so a team of anesthesiologists, intensive care physicians, bioengineering came together and developed a COVID box. What you see on the left side of the screen is a box with ports where one can insert either equipment or hands for example, airway management. And then on the far side of the box, there's opening where the patient's torso would be and the head would kind of be lying inside of the box. And what makes this really neat is the fact that they've attached basically vacuum to it that would allow the creation of negative pressure and thereby less exposure in the surroundings of the patient and potential for us to safely perform some of the procedures and also to protect the providers. On the middle picture, you see how the box is set around the patient's head, or this is the mannequin's head. And then the big thing, silver thing on the top is the attachment that would create negative pressure. In the hospital, we have negative pressure rooms, which are intended for anybody who has an infection that's very risky, but those are very few. And they are in very short supply everywhere across the country. So this would allow for enhancement of that negative pressure environment in a much cheaper way. And it would be a really, really neat discovery. And what we'll show you in a second here is a video of how the negative pressure that's created kind of prevents escape of any sort of, in this case, smoke from the box itself. Nick, we can start the video. So you see this will light up, and then in just a little bit, there will start to be some smoking going on inside the box. And smoke is about sort of a micron size particle. So it's bigger than the COVID virus. But in just a second, you'll see how the smoke starts escaping through the ports. It's pretty visible. This would be a risk, obviously, for exposure for anyone. And it's quite impressive how much kind of escapes through the openings. And then we've turned on the suction to create negative pressure. And then the smoking from the ports, as you can see, pretty much stops.
It's on, as you can hear.
And you can see the smoke moving upwards into the exhaust. And so this was basically, we can stop the video. This was basically the proof of the concept that we can create negative pressure environment inside of
Smoking, but as you can see, there's no release of smoke from the device.
And let's move to the next slide. We love watching this video because it's so cool, but I think you've had enough of it. So as far as spread studies, basically two things came out of it clinically. The protocols for so high fidelity oscillator was one of the ventilatory techniques we were studying, and that in particular was releasing Glo Germ everywhere. So neonatal intensive care unit created clinical protocols that were different from previous ones in order to ensure safety of personnel and safety of patients around them. Also, the non-invasive positive pressure ventilation use in ICU was now supported by our evidence that the use is not recommended, and the clinical protocols were equally modified. I think these are important contributions of our center to what's going on in the hospital. Protective box is now being actively used in clinical environment and has allowed for additional procedures to be completed by the bedside. And the future projects are gearing up to try to prove that it would be safe to use it in patients that need non-invasive ventilatory support. And clearly, if we can use this, then the use of personal protective equipment could potentially be decreased again and save what we have for the times when we really, really need it. Next slide. The second larger group of themes that came to us was the need to uptrain healthcare providers on the front lines. Just at baseline, healthcare providers, especially nursing, are in shortage. That's true of every hospital in the country. With COVID-19, a need for intensive care unit trained nurses increased exponentially because a large percentage of patients with COVID-19 end up in the ICU. So the hospital were basically facing an issue of not being able to recruit new nurses with particular set of skills. And the solution to that then ended up being, can we uptrain our own employees towards what we need and create sort of extenders of specific hospital areas. So the ask came to us to uptrain nurses and nurse anesthetists to their maximum scope of practice. Next slide, please. And we felt like this is a very important mission, and also found a way of using our own trainees who have a little less to do due to hospitals trying to create space for COVID-19 patients as people who would train our nursing staff. These were clearly senior residents who have achieved entrustable professional activities related to what we were training on. And this provided, I think, a very, very positive experience for both, for all the nursing staff and nurse anesthetist staff who went through the experience, and then also for us being able to provide the training. What we're showing in the image specifically is central line training for nurse anesthetists. We also train them with arterial lines. Now, these are skill sets that nurse anesthetists mostly learn in their training. However, some of the hospitals have policies where they don't necessarily do them on a daily basis. So they were very happy to be able to get this additional training. We've also sort of created a system where the simulated training is then followed up by clinical experience with a proctor to allow for everybody to ensure patient safety. We've also created training modules for ICU nursing to learn how to manage anesthesia ventilators. Now, ventilators are kind of, similar in a sense, but there's definitely differences between anesthesia machine and intensive care unit ventilators. So we've created educational units to achieve the training in that. Now, when we received this request, this is how it went. Nick, can you go to next slide? So it was Thursday afternoon when we got the call that ideally they would like to train about 60 people between Monday and Tuesday. And the short notice was due to the fact that the local COVID-19 hospital was admitting more and more patients, and they felt there would be a need for this training to be completed fairly quickly. And the sort of the background to this, why we wanted to do this training, was that the same individual would intubate the patient, place a central line, place arterial line. This would limit the use of protective equipment to one person, and also limit the exposure to a COVID-19 patient to one person, both of them clinically desirable. And Nick will tell us a little bit about how we went about securing the funds to actually be able to do this.
Thanks, Mojca. Yeah, so as was mentioned, we got this request on a Thursday, and what we were able to do was use our established rates, and I came up with a budget pretty quickly that was submitted, and by the very next day we had funding, and we're getting ready for the next week in terms of logistics and getting people in to train for this. So having a turnaround that time in such a short amount of time is something I've not experienced before.
And I think we were really fortunate that basically the command center, COVID-19 command center for the hospital, clearly had great interest and committed some of the greatest needs funds, which is funding that usually supports this kind of stuff. They've committed a significant chunk of that to these activities and funding of them, because clearly this is quite a massive training of quite a significant number of people in very short time. Let's go to the next slide. And then Eugene's going to share with us a little bit about our in-house sort of cheap version of models that we can put together relatively quickly, as you will see, and we'll provide the recipe to you. We'll go through it, but then if anybody would like the recipes, you might already have this. We are happy to share.
Yeah, thanks, Mojca. So before I actually get into the stepwise process of how we created the models and how we go about doing it at our center, there are a few things to consider after the funding was actually acquired, and we kind of just further logistical considerations. These will be unique to each of your centers, but I just wanted to briefly mention a few of the ones that we had to take into account. The first one was space. So not only which rooms are best suited to actually be conducting training like this for central line or arterial line training, but then also where are you going to be able to actually lay out the numerous molds for these models as you kind of go through the stepwise process of creating these trainers. Second was time, not only the time required to assemble the molds for each model, but then also the time it required to mix and pour the skin gelatin that we use, and then that also the time for the models to cure. So with all of that, taking that all into account, you really want to keep these in mind before you officially settle on when the course will be able to actually take place. So now, again, I'll go through the kind of stepwise process that we utilize to create these models that you see in these 4 pictures here. The top right photo there is the actual completed model, but we're going to start over on the left-hand side in the top left corner. The first component to this is actually going to be creating the vessels, the vasculature. For this, we use a 3/8 Penrose strain and also a 1/4 inch Penrose strain. One is to represent the arterial vessel, and the other is going to be for the vein. The main difference that comes when creating these is what's going to be attached to the one end. So one side of it, we're going to tie a knot. We're going to fill one with blue colored, basically just food coloring or water, and then one with red. For the red, we're going to attach, which would represent the artery, we're going to attach just a simple suction bulb that you can see in that top left photo. And for the blue, we typically like to use just cheap umbilical clips. That allows us to actually pressurize the line for the vein, so that as it gets set into the mold, as you see in that top left picture, and we pour the skin in, it doesn't actually collapse. So that's really the first component, is being able to set up those two vessels. And then you can move on to the second component. One thing to briefly mention too is before you move on to each component, we highly suggest that you kind of complete the process for the amount of models that you are planning to create. So for us, we created 50 veins, 50 arteries for a 50 model class that we were doing. But as we move on to the second component, we're really going to get into how to set up those vessels and the actual molds that we use. The plastic molds you can see in the top left photo are just 3x6 plastic molds. And how we set those vessels inside is actually using just simple 1-inch office binder clips. The main point to this is that you ensure that the vessel is not touching the bottom of the mold, nor is it rising above the top of the mold. As you can see in the bottom right-hand photo, if the vessels are kind of centered properly in the mold or in the model, you're able to get that good view of the two separate vessels. So as you set those in, just keep that in mind that they should be kind of floating in between where the actual mold is. Next, we'll move on to the third component. And the third component comes down to actually adding a suturable layer to the model. This is important for any arterial line and central line training to actually secure the line after it's put in place. So what we like to use is just simple nylon stocking. We usually use a shorter nylon stocking that's able to wrap around that entire plastic mold. We then cut just a small slit above each of the binder clips that allows that nylon stocking to actually slip over the binder clips and sit flush with the top of the mold surface. That's important because as we go to pour in the skin, it allows that nylon layer to actually embed in the very top layer of the skin, and that allows it to be suturable. The fourth and final component to making these models is actually going to be the creating of the skin gelatin. So I'll just briefly run through kind of the mix that we use and what that looks like. So we start off with 1,200 milliliters of water, 800 milliliters of glycerin in a large glass bowl that can be put in a microwave. We then mix the two powders, which for us, we use 300 milliliters of Knox gelatin and 2 tablespoons of Metamucil or some type of fiber, which really helps to add quality to the image that's seen on the ultrasound. As you're mixing in that powder, you want to be conscious of not letting any clumps develop. That'll create kind of a distraction for the learner as they're going to ultrasound the model. And then as you finish up mixing in the powders, the last step is just to add in the 2 ounces of acrylic paint. And we use any skin tone, works just fine to ensure that that's fully mixed in. After that, the entire mixture can go into a microwave for anywhere from 4 to 5 minutes. And when you take it out, we usually let it sit for 1 to 2 minutes. That's important because it allows the gelatin to actually set a little bit, which then, as you pour it into the molds, it'll allow that nylon stocking layer to actually embed into the top layer of the skin, where if it's too hot, it'll just tend to float on top. So now we look at kind of the cure time that it takes for these models to fully set. We usually let them set overnight. We'll make them, later in the afternoon, let them set overnight, come back in the morning, and work on cutting them out of the molds and then positioning them on a tray that will then get put in the refrigerator. Similar to what you see in the top left corner, we'll position 5 on a tray of just the actual skin molds, and then we'll layer we'll put a layer of saran wrap, which helps to keep the moisture in the molds. And then we'll put that entire tray into the fridge. At that point, they can keep from anywhere from 30 to 60 days. One thing to keep in mind is if it goes over that time period, the edges will start to get almost a crusty layer to them, which is just the water evaporating out of the mixture, and they'll no longer be able to be used for ultrasound. So in the end, once you're getting ready to set up, you can see in the bottom left-hand photo what our setup looks like for central line placement, which includes 2 stations on a table, 2 kits. In the middle there, you'll see the ultrasound probe covers. And then on each side, you see the model, which is just kind of a basic draping that we use around it. So now I'll turn it back to Mojca to kind of discuss our outcomes that came from this.
Thanks, Eugene. And we're gonna go to the next slide. So this is the result of the actual personnel training that we helped with. We've touched 501 staff in about 2.5 weeks. This was between the two institutions, the university hospital and VA. ICU nursing extenders were identified and trained from normal nursing towards an intensive care unit nursing. We talked about CRNA skill training, and then we also participated in emergency room teams training on donning and doffing, and this was rapid donning and doffing since they frequently encounter quick acute clinical situations where there is limited time to do this. And then we've gone through intubation and CPR training on COVID-19 positive patients. And this actually rose a few interesting questions. As we were doing the CPR, the question arose whether the CPR can aerosolize, especially if you're using the automated chest compression machine, Lucas, for example, and we've determined that we will recommend full protective equipment for that, thinking that it does aerosolize the virus. So I think this is important because we've helped with the expansion of clinical potential within the hospital quite significantly. I think this may also impact the future practice in our system because you've now basically uptrained significant number of people with additional skills, not necessarily additional skill sets, but make them comfortable with the skill sets they would have known previously or just didn't use currently. Please, next slide. So the third larger group of things that we've been asked to do is basically help with the investigation of clinical environment as it's getting repurposed, and then also with study of repurposing some of the medical equipment within the hospital in the COVID-19 time. So in terms of investigation of clinical environment, this is clearly nothing new. We've used it to study the processes and potential latent errors, accidents kind of waiting to happen, study the equipment within the clinical environment. So that's nothing new. What was new to us, I would say, was the decision-making process of what we feel comfortable with in terms of sending our personnel into the clinical environment. We were, in a sense, lucky that the place that was being repurposed from preoperative assessment area into the intensive care unit environment was newly built. No patient has ever entered that environment. So we felt that was pretty safe, and we felt good about going in there after acquiring all sorts of permits from the university president's office and the hospital leadership. And I think we were very successful in supporting their effort, and we were able to identify certain things to increase patient safety and also provider safety. And then in terms of the other groups of studies, they were related to repurposing of non-invasive positive pressure ventilators into an intensive care unit ventilators that would be used with intubated patients. This is another very important area because of the shortage of ventilators. If we go to the next slide, these are some of the titles from the news outlets over the past few weeks, and the ventilator shortage is real. If you think about it, normally in a year, about 77,000 new ventilators meet the demand of the whole world. In April, just New York City alone required 30,000. So this is a significant increase in the need. And clearly the supply has not met the demand. And this then leaves clinicians in a really horrible, potentially horrible situation of having to decide who gets the ventilator and who doesn't. So our intensive care physicians embarked on trying to study the non-invasive positive pressure ventilators that are usually used. For example, people will probably be familiar with CPAP masks that you can use when you have obstructive sleep apnea. So it's those types of ventilators that we were studying to try to repurpose into a ventilator that could support a patient with a breathing tube. Next slide. And so this part of our efforts were kind of interesting. We do not have access to the fancy respiratory software that is provided for more accurate respiratory physiology. So we started off by trying to figure out what the actual mannequin's respiratory physiology is. We did that using the intensive care unit ventilator, which provides a lot of feedback information in terms of things like, for example, is there a leak in the system? We've determined there's a small but persistent leak in the mannequin. We've also identified that resistance and compliance are resistance is really high compared to human, and compliance is lower compared to human, which is things we've expected. But we've kind of defined what the baseline is with a ventilator we know works for sure to ventilate patients with significant lung disease. And then we went and took the non-invasive ventilators and basically studied what kind of settings would these machines have to create in order to be able to successfully ventilate a patient. During this process, we've identified that there are significant challenges or maybe limitations of the circuit, so the tubing that goes from the machine to the patient, that are normally used with these types of machines. And the subsequent studies in the biomedical engineering school created new circuits that can be used with these types of ventilators and would be able to deliver ventilatory settings that would be acceptable to use in an adult patient that has the need to have ventilatory support and be intubated. Let's go to the next slide. So in terms of our studies in the clinical environment, in terms of repurposing of either environment or equipment, so the component of environment studying the identified errors in clinical protocols, which we were able to correct with the hospital leadership, and they're basically documents that then get post-published for everyone to see after they have been vetted by the command center. And we've also identified very specific mechanical issues within the clinical environment that was going to be repurposed, which helped with just getting the engineering in there and fixing what was not working properly. So I think this was a successful mission. And then in terms of the ventilator studies, I think those were certainly pretty interesting studies. We learned stuff about the mannequin. We've also learned stuff about the non-invasive positive pressure ventilators, which we have not known before. And studies are underway of how to use them successfully in clinical environment. The studies that follow are usually animal studies, and then we go from there. Next slide. And so these are basically just a slide presenting to you some of the outcomes of our efforts. The studies we did with Glo Germs, one component of them studied how far into the anesthesia machine does the virus potentially travel. Glo Germ is a bigger particle, so if that travels as far as it did into anesthesia machine, then for sure the virus does. And where that is important is the cleaning of the machine changes drastically between the two. And of course, in patients, we would use HEPA filter, but now we were able to provide visual evidence of how far the particles can travel within the anesthesia circuit. And that component of our investigation got published on the Anesthesia Patient Safety Foundation newsletter site as a letter to the editor, and I think it's being shared with the community that needs to know about this. On the bottom left, you see a very sort of, deconstructed anesthesia circuit. This was the product of ventilator studies, and what is shown there are the valves that were necessary to be embedded into the circuit to make this, the circuit for the ventilator useful and able to create the volumes for ventilation that we would need in an adult person. So this is now being put into a small box and would be a part of the circuit that would be used with the patient. And on the right side, we see the box with the exhaust, and then one of my colleagues intubating a mannequin with the box over the mannequin's head. This has now moved further, and we've been using it within the operating room to accomplish certain procedures which we previously would delay as far as we could potentially. So I think overall we were very, very excited about being able to contribute meaningfully in terms of hospital environment itself, in terms of innovation around the COVID-19. So I think it's been kind of a little bit crazy with the intensity of the demand on us, but I think also very fulfilling to feel that we are part of the process. It's also been, and we've seen that as we polled your answers, that we do have institutional support, which I think that is very important for us. And I think showing our presence kind of enhances that understanding of us being part of the healthcare environment. I think with that, we will complete the presentation and maybe answer a few questions. I know there's been some back and forth already going on in the chat, and some information has already been exchanged, but maybe Lou will lead us through some of the questions. I think we, if you want to unmute yourself.
Thank you. Thanks for having my back there. Okay, so thank you all so much, and we'll do a few questions, and we've got an interesting one here. I'm going to go to Mojca on this. How are you using the term uptrain as opposed to just regular training or training generally? What are you thinking about?
So basically, you are, for example, taking a nurse that would normally work in a regular ward, and you're adding to the skill sets or refreshing the skill sets that are particularly used in the intensive care unit environment, which are, as you can imagine, a little more higher end skills. Now, the intent was not to replace intensive care unit nurses with the floor nurses. The intent was to create extenders where then you maybe need one intensive care unit nurse that can maybe supervise 2 or 3 floor nurses in the intensive care unit environment. So these are all solutions for a really sort of situation maybe that is being experienced in New York, where everything is basically functioning to over their maximum capacity. It's also intended to prepare us for the fact that some of us would get sick and you would experience shortage because of just healthcare providers having to stay away. So it's definitely not something that one would do in normal circumstance. For nurse anesthetists, on the other hand, they do get trained for central line and arterial line placement. That's part of their scope of practice. It's just that within certain hospital systems, the organization of workflow is such that they don't necessarily do this on a regular basis. And clearly, when they were asked if they would be able and willing to do this, they asked for refresher courses, and that's what we were basically providing in conjunction with the component of this that would be happening in clinical environment.
Great, wonderful, thank you. So I see, I'm just gonna say real quickly, we won't answer these right now, but I see a lot of questions about what's the mixture of the mold. I see if you all make models, can you record or take a step-by-step series of pictures? That was awesome and has a significant cost savings. So we want to be clear that we are happy to share this information with you so that it can help your teams. Maybe we have time for one more question. You can tell this is from another anesthesiologist, I think. What kinds of lungs did you use? Depending on what you use, compliance is not that much of an issue. What do you think about that?
So, I mean, we just were basically using what is contained within the 3G SimMan. So it was just understanding what exactly that particular lung does. Interestingly enough, when you hook up the ICU ventilator, the pressures that were allowing for a reasonable tidal volume when you had significant resistance on were like in the 50s and 60s, clearly not physiological and clearly problematic in terms of making any conclusions with our stuff. But it was a piece of information that we used to then translate into the non-invasive ventilation. So it's not normal human physiology. Part of what was fun was like the ICU docs kept asking, okay, well now we're gonna have a patient take a breath, and clearly it took a lot of effort to make them understand that that's just not gonna happen. Yeah, so that was kind of what was going on.
Great. Well, thank you for that. And if you do happen to have that occur again with those docs, please get video footage of that, because that sounds kind of fun to see. We can feature that next time. So thank you for responding to a few of the questions, Mojca. Nick, I'm going to ask you to just send us to the next slide, if you would. We have a couple upcoming sessions we want to share with you. Our very next session from our friends and colleagues over at UIC, they're doing a session on using Zoom to audition potential standardized patients. That's coming up Wednesday at 11 a.m. So go check it out for all of you who are looking to do that. Next slide, please. And then 2 weeks from today, right here, 11 a.m. Central Time, I say right here like you're all in my kitchen, but right here, we're going to be doing navigating leadership, managing remote work teams in the COVID-19 response. This is a collaborative session from us at Minnesota, and also from Dr. Christine Park and Bob Kaiser, the leadership with UIC's SAIL Institute for Simulation. Mojca and I will be joined by Ann Wool, also our education director at MSIM. And the five of us are going to be thinking about, considering, and sharing some practical tips on what we've been doing to try to help manage and support our remote work teams during this time, and also considering the human factor of what this means and supporting all of us in our wellness. So with that, I really want to thank our presenters today for their excellent work. I want to thank all of you for being here with us again, and wishing you the best, wishing you a safe and healthy weekend. Thank you for all the work you're doing and for being a part of our webinar today. Take care.
Bye-bye.